Hello and welcome to Best of the Day from the 21st annual meeting of the Network for Oncology Clinicians and Researchers, meeting once again in Las Vegas, Nevada. So we're going to be doing two of these Best of the Day segments. The first one today will cover breast cancer, melanoma, and GI malignancies. And we're going to start this segment with Dr. Ruth O'Regan, who recently moved from Emory University in Atlanta to the University of Wisconsin in Madison, where she is professor of medicine and division chief of the Department of Oncology. So Ruth, welcome once again to Best of the Day. Always good to see you.
Thanks, Jim. Good to see you too.
Well, it was an interesting session this morning, really a varied program. And I thought Jeffrey Weitzel's presentation on the genetics of breast cancer was especially interesting. We all know about BRCA1 and BRCA2, but now there's this new PALB2 mutation that is getting a lot of notice. And I think one of the somewhat confusing things is how to advise patients who think they might be at increased risk because their mother or their aunt has breast cancer or their sister develops breast cancer, and they want to know whether they should go the Angelina Jolie route or what to do. How do you approach this situation, and what kind of guidance did Dr. Weitzel provide us?
Well, I think his guidance was actually very useful because if you remember, he went through the NCCN guidelines and kind of picked out some very simple things that we should be looking for in our patients to decide whether they warrant testing or not. Of course, as we all know, there's certain things that we always are concerned about in terms of testing for BRCA genes, such as multiple family members with breast and ovarian cancer, and then this newer NCCN guideline of the triple negative breast cancers in women up to the age of 60 is recommended to test those, and obviously male breast cancer as well for BRCA2. So I think taking as detailed a family history as you can is obviously very important. I would strongly recommend that the genetic counselor is involved, because I think they really are the best people to just sit down and do the family history and discuss risks and pros and cons with patients. So that's usually what we would do. But I think overall we tend to follow the NCCN guidelines in terms of testing. Now, one of the things that's made this a bit more complicated is that historically we've sent for BRCA1 and BRCA2 testing. Now, obviously, there's certainly a lot of other hereditary genes out there that were not so clear-cut in terms of what they mean. And as you're probably aware, there is a panel that gets sent off, which essentially is looking at genes within that BRCA1, BRCA2 DNA repair environment, of which PALB2 is one of them. And, I'm all for the research of that, but the problem is that these panels are coming back with information that's very hard to interpret. And I think it's certainly confusing for the patients, but I think it's also confusing for us. So, for example, PALB2 is involved with BRCA2, but we don't really know what, in terms of what the risk of breast or ovarian cancer truly is with that mutation in PALB2, and likewise we really don't know what to do with when we find that. So I think it's going to take more research to try and work out exactly what these other mutations mean. They're interesting to send, but I think you should definitely just be careful about it, just because I think it's very confusing for us and for the patients right now.
So if you have a patient with triple negative breast cancer, and testing indicates that they have one of the BRCA mutations, what do you tell them about their siblings, about their younger and older sisters? What kind of advice, if they say, well, I've got two older and one younger sister, what should I tell them?
So I think if the patient has a BRCA mutation, then obviously the siblings are definitely at high risk. So at the very minimum, they need to have their screening, probably be seen in a high-risk clinic. And I think overall, they need to be seen and decide whether they want to have BRCA testing done or not themselves, because obviously they certainly may choose, or we would probably recommend bilateral oophorectomies once they finish childbearing, but they may also want to consider surgery to their breasts as well. So I think what I would generally say is find out if there's a high-risk program near where they live, so you can get them seen, have formally tested for BRCA, and then recommendations going from there.
And if they've completed their families, should they consider bilateral oophorectomy?
I think bilateral oophorectomy, there's no question that has been shown to be beneficial, firstly in reducing the risk of ovarian cancer, but then this very strange finding that it also reduces the risk of breast cancer in BRCA1 mutation carriers, even though they usually get triple negative breast cancers, and that's never really been explained very well. But I think in terms of if you know a patient has a BRCA mutation, that's one thing for absolutely sure that we're going to recommend to that patient. I think if you have a sibling of a patient who has a BRCA mutation and they choose not to get tested, it's kind of up to them, but I would probably recommend that they consider it because they really could be at very high risk.
Very good. Well, Christy Russell updated us on adjuvant therapy, and one of the things that she mentioned were some of the ongoing trials that involve genomic profiling, the TAILOR-X and the MIND-ACT. Are those trials ever going to be completed? It seems like we've been talking about them for 10 years now.
Well, the TAILOR-X trial, both of them are actually accrued. The TAILOR-X trial has been closed for actually, a number of years at this point. And just to remind you about the design of it, it was looking basically to try and find out, where the cutoff chemotherapy benefit is for patients with node-negative ER-positive breast cancer. But as you also recall, the intermediate group ran from a recurrence score of 11 up to 25, despite the fact that the benefit of chemotherapy in the initial trial was seen really only in patients with a score above 30. So it's possible that the cutoff for chemotherapy benefit doesn't lie between recurrence scores of 11 to 25, which means it's going to be quite a while before we get some results from that trial. I'm sure they're doing interim analysis and they may want to present the data even if it's not showing anything conclusive. But also remember there's a lot of tissue collection on that trial, so I think we learn a lot of things as well as kind of where the cutoff recurrence score is. The MIND-ACT trial is the European trial which is using the 70 gene signature. And it's a slightly different design than the TAILOR-X trial because what they do is you basically estimate a patient's risk using the classic criteria that we've always used and then the 70 gene signature. If both are low, the patients get endocrine therapy. If both are high, patients get chemotherapy followed by endocrine therapy. And they're randomizing the discordant results. So if you have a low risk by the classic criteria but you're high risk by the 70 gene signature or vice versa, they're the patients that get randomized. Now that trial does allow patients with up to 3 positive lymph nodes, so maybe we'll see some results from that a little bit more quickly, but I haven't heard anything with regard to it being presented anytime soon.
It's just going to take a while for enough events, as we say, to occur before there's statistically significant data.
Exactly, and these are lower risk ER positive cancers where we know that you really have to follow these patients quite far out before you see anything. So it's just not clear at this point, but obviously both very important trials that I think will really help us towards really being able to tailor which patients need chemotherapy with ER positive breast cancer.
Well, Christy also talked about the soft and text trials that have been presented at various meetings, and I think there was an update at San Antonio. What is your takeaway from those trials in premenopausal patients who are hormone receptor positive, and what is the take-home message for the community oncologist?
So it's reasonably clear-cut, but not 100% clear-cut. So both these trials are basically looking at tamoxifen as a control arm with either tamoxifen with ovarian suppression in the soft study or exemestane plus ovarian suppression in both the soft and the text study. They both are showing a benefit for ovarian ablation. And in the soft study in particular, there was a significant benefit for exemestane plus ovarian ablation, particularly in younger women under the age of 35, and also those that had potentially higher risk cancers, which were the patients who got chemotherapy. So I think overall, if you have a young patient, it definitely is appropriate to discuss ovarian ablation with them, with potentially the addition of exemestane, although the tamoxifen arm also with ovarian ablation also showed some benefit. I think the questions that come up are if they're slightly older premenopausal patients where maybe you didn't give them chemotherapy, that group really didn't appear to benefit as much. So I think there's still some gray areas. The other big questions are what do we do for patients that we have right now who are on tamoxifen? alone? Do we add ovarian ablation in now and put them on an aromatase inhibitor? And these are all questions that I think are a little bit tricky to answer at this time point. But I think it is practice changing in that if you have a younger patient with an ER positive breast cancer, the data I think was impressive enough that you would consider ovarian ablation plus exemestane, with the caveat that I would imagine there's going to be compliance issues with that, since sometimes you can't even get them to take tamoxifen, never mind ablating their ovaries as well.
So ovarian ablation could be either surgical or radiation or chemical with a drug like goserelin. How well was that tolerated in conjunction with the aromatase inhibitor or tamoxifen?
Well, I mean, there were definitely compliance issues with it. I mean, obviously you're putting patients into, pretty abrupt menopause. So, overall, I think there was quite a lot of toxicity associated with that approach over what you would see with tamoxifen, which is really quite well tolerated in premenopausal patients. And I would say the one caveat I think we have to keep in mind is that the most important thing is for these women to stay on some form of endocrine therapy. And certainly if I had a patient who couldn't tolerate that, I would put them back on tamoxifen, because it's certainly better for them to take tamoxifen than nothing. I think that's important.
So in these trials, it was 5 years of endocrine therapy. Is that long enough?
Well, see, that's the other big question, because, we now know, of course, that we now have, several trials that show that 10 years of either tamoxifen or tamoxifen followed by an aromatase inhibitor is better than 5 years of tamoxifen. And of course, neither SOFT nor TEXT had a comparator arm with the longer duration of tamoxifen. So I think that's a big question as well. And I would say, just going back to what we were talking about with the 21 gene recurrence score and the 70 gene signature, that type of molecular profiling I think is going to be very important to work out, which of the patients need ovarian ablation plus perhaps an aromatase inhibitor versus which patients just need longer treatment. And that's a big question right now. And as you know, the Atlas and Atom trials, there's just no molecular profiling from those as yet. And I just cannot imagine that every patient with an ER positive cancer needs longer treatment. But right now, we don't know who they are.
Very good. All right, Mark Pegram gave us a great update on the recent advances in HER2 positive disease. And can you give us a little bit of information as far as the guidelines are concerned? What should you do in the neoadjuvant setting as opposed to the metastatic setting with the availability now of trastuzumab, pertuzumab, TDM1? How do these all fit together?
So interestingly, the first-line metastatic setting and the neoadjuvant setting are quite similar, actually. So in the neoadjuvant setting, it's recommended to use a pertuzumab-trastuzumab combination, either as per the NEOSPHERE study, where you give with docetaxel and then potentially follow with an anthracycline, or per the TRIFENA study, where you give what is the old TCH, docetaxel, carboplatin, trastuzumab with pertuzumab. They're kind of your options in the neoadjuvant setting. I think there's a lot of questions with that. For example, in NEOSPHERE, could you get away without giving anthracycline to some patients? We don't know that at this time point. The other thing just to mention is he did mention that the NCCN had actually endorsed using pertuzumab with trastuzumab in the adjuvant setting as well, which, as you know, we don't have any data for right now, which is a little unusual. I know people are doing that if they can get it paid for. In the metastatic setting, it's actually quite clear-cut. The NCCN recommends pertuzumab, trastuzumab, and a taxane in the first-line setting, and the second-line setting, most likely a trastuzumab DM1-based regimen. Now, as you may know, the Marianne trial was a trial that was kind of designed to look at adding trastuzumab DM1 and pertuzumab together and comparing them with really standard treatment with trastuzumab and a taxane, which was docetaxel. Well, we have very high hopes for that because trastuzumab DM1 have been shown to be somewhat better than docetaxel trastuzumab in a small randomized phase 2 study. We do not know the results of Marianne, but we know from a press release that it doesn't appear that there is a big difference between the arms on that study, which in my mind would mean that I don't think the guidelines are going to change in terms of the first-line setting anytime soon. So for me, usually I would do pertuzumab, trastuzumab, and docetaxel first line, obviously dropping the docetaxel once you got to a point where you had a good response. And then in the second line setting, trastuzumab DM1 would probably be my choice at this time point.
So in the adjuvant setting, we usually would use something like AC or TC along with trastuzumab and then follow it with a taxane. why the reverse in the neoadjuvant setting? Why start with the taxane first and then follow up with the anthracycline?
You know, I don't honestly know the answer to that, and I don't know if the thought was, well, you're probably going to get less cardiotoxicity by avoiding the anthracycline up front. If you look back at some of, the original adjuvant trials that were done, there were patients that dropped their ejection fraction when they got the anthracycline component, which actually prohibited them from getting trastuzumab later on. So I think that was really the thought behind it, was so that you could basically get them started on trastuzumab or HER2-directed therapy as early as possible.
So let's move on to your talk, to the triple-negative breast cancer talk, and the importance of whether or not you're a basal-like or non-basal-like, and how important is that, and does it really matter that much in your choice of therapy?
I would say at this moment in time, it probably doesn't matter too much. There was just some interesting data from the CLGB study, if you remember, that was looking at adding carboplatin, right, and or bevacizumab in with a backbone of paclitaxel followed by AC. And in credit to them, they did a lot of correlative studies from that trial. First of all, they showed that by far the majority are basal-like, almost 90% were basal-like, and there was a smattering of claudin low and luminal within the group. The pathologic complete response rate didn't differ overall in the group, whether they were basal-like or non-basal-like. And most importantly, because what we really wanted to know from that study was, are there patients we can avoid carboplatin in? But unfortunately, the PAT-CR rate was higher when you added in carboplatin, whether it was basal-like or non-basal-like. So it doesn't give us a hint of a group that, either we could avoid carboplatin with or that need carboplatin at this time point. So I think from that trial, it isn't that helpful in terms of making decisions. The other thing that was interesting that came out of San Antonio was the TNT trial, where they were basically looking at carboplatin versus docetaxel in the metastatic setting. And they, for some very interesting reasons, showed that in non-basal-like cancers, the response rate to docetaxel was almost 70% compared to only about 30% when you gave carboplatin. But in the basal-like, the response rate was really equivalent between the carboplatin and the docetaxel. Now, I don't think we can say anything about that at this time point, but I think this type of data is very important because it reminds us that these triple negatives are not all the same, and there may be differential benefits of various chemotherapy agents based on this type of subtyping.
Is there any evidence to suggest a different response in the triple negatives basal-like who happen to be BRCA mutated as opposed to BRCA wild type?
Yeah, I mean, yes, there is. And I think, again, the TNT study did look at that. And it's pretty clear now that if you were a BRCA1 or BRCA2 mutation, platinums are more effective. In the group they had on the TNT study that had BRCA mutations, there was a very high response rate of about 70% to carboplatin, not seen in the docetaxel arm. And that supports, I think, a lot of data that we've seen before. So I think that's an important point to make out as well.
In the metastatic setting, are there any trials adding a PARP inhibitor to carboplatin in the BRCA mutated? We remember the studies with the first so-called PARP inhibitor with gemcitabine and cisplatin, and that did not pan out in phase 3. But with some of the newer, more true PARP inhibitors, are those studies being looked at and moving forward?
Yes, they are. The Abbott PARP inhibitor in particular, there's a large study looking at that specifically in BRCA1 and BRCA2 mutation carriers who have metastatic disease. So that's an ongoing trial as well. I think one of the things with the PARP inhibitors, and maybe the platinums to a lesser extent, is it would be nice to be able to define a group of patients who didn't have BRCA mutations but had triple negative breast cancers that kind of had that BRCA-ness phenotype. And so far we just don't have a way of doing that, unfortunately. So I would say at the moment PARP inhibitors are probably restricted to patients with BRCA1 or BRCA2 mutation, because of the issue of the fact that the PARP inhibitors cause single-strand breaks. The BRCA1 and BRCA2 mutated cancers have an issue with double-strand DNA repair, so it's like a double hit on the cancer cell, essentially, when you have both together.
So finally, what about the cyclin-dependent kinase inhibitors? We just recently had an approval of the first one. What do you see as the role of these agents moving forward?
Yeah, I think the ER-positive metastatic setting is quite exciting right now in terms of new agents. So as you recall, there was a randomized phase 2 study that was presented several times, but in the last couple of years or so, where they took patients in the first-line setting and randomized them between letrozole or letrozole plus palbociclib, which is the Pfizer CDK4/6 inhibitor, and they saw a doubling of progression-free survival in that study.
Very impressive.
And when it was presented first, it was even more impressive, but with further follow-up, it still remained impressive. So even though there's a phase 3 confirmatory trial pending, the FDA did approve this regimen a few weeks back. So we now have this as an option for patients in the first line setting. A lot of questions, obviously, because obviously it's a well-tolerated drug. There's really not that many side effects, but it's going to definitely add to the expense of the regimen.
Some economic toxicity.
Economic toxicity, exactly. Then you also have this interesting finding from that first trial that compared fulvestrant with anastrozole, showing that improves survival. And, so it's a little bit of a conundrum, but I do suspect that if we have patients who are candidates for non-steroidal aromatase inhibitors in the metastatic setting, a lot of us will go ahead and try and give them palbociclib in the first line setting. One of the reasons for that, of course, is that we don't have any data outside the first line setting. So if we don't give it in the first line setting, we may be not able to give it at all. So I think that's one of the things we're struggling with. And I'm hoping that we'll see some trials looking at CDK inhibition through progression to see what we should do at that time point. And there are 2 other agents out there. One Novartis has, and the other one that Lilly has, that have kind of copycat trials, but there's also the Novartis one has been specifically looked at in premenopausal patients with ER-positive metastatic disease in the Mona Lisa 7 study. So I think that will be interesting to see as well. So I think these are interesting drugs because they seem to work and their toxicity is low, because that's always, of course, something we worry about with these patients, because endocrine therapy itself is not really very toxic. So you don't want to add in another drug that's going to be more toxic or maybe as toxic as chemotherapy.
Very good. Ruth, thank you so much. This was really interesting. It's been a great meeting so far, and there's still a lot more to come here in Las Vegas. So thanks so much for sitting down with me.
Well, thanks for having me.
All right. And thanks to you all for watching this. There is the next segment coming up with Dr. Richard Carvajal from Columbia University on malignant melanoma. So please stay with us. So welcome back to Best of the Day from the 21st annual meeting of the Network for Oncology Clinicians and Researchers. During this segment, we're going to be talking about melanoma and some of the really interesting data presented at this year's meeting. And joining us for this session is Dr. Richard Carvajal from Columbia University in New York, previously at Memorial Sloan Kettering, but now heading up the melanoma program at Columbia. So Richard, thanks so much for coming.
Thank you for the invitation.
Well, I thought this morning's session on cutaneous malignancies was really interesting. Elaine Alghazi from UCSF talked about the BRAF mutant population, and then you covered the amazing advances in immunotherapy, really for both BRAF wild type and mutant. So let's start off with the BRAF mutant. I think everybody was surprised several years ago to learn that this BRAF V600E mutation was so common in melanomas, and that there were excellent targeted agents. So we have vemurafenib and we have dabrafenib. They're both highly effective, but the duration of response is somewhat limited. And tell us a little bit about the resistance mechanisms and what kind of progress has been made in addressing those resistance mechanisms.
Yeah, so I think you're right. I mean, the meeting today has been fantastic. And, I think what both Elaine and I discussed was some of the incredible advances both in targeted therapy and immunotherapy for melanoma and how this can be a model for other diseases. The BRAF story has been phenomenal. The finding of these frequent BRAF mutations in melanoma was in 2002. And in relatively quick time, I think, the approval of vemurafenib really revolutionized the treatment for these patients. But, with vemurafenib alone or with dabrafenib alone, now we're seeing significant response rates, but durations of disease control now about 5 to 6 months.
Right.
And so the next step is to really figure out why is that happening and how can we overcome that? I think what's been very interesting is that the mechanisms of resistance have been very diverse. So it's not like we're finding gatekeeper mutations like we are in other diseases. Right. And there's been a lot of work elucidating various mechanisms, for instance, overexpression of RAF, increased dimerization of RAF with BRAF and CRAF, expression of the COT kinase. A lot of these mechanisms function by activating the MAP kinase pathway, despite the fact that you still have effective BRAF inhibition.
Through different mechanisms.
And so somehow the cell is able to reactivate that critical pathway in melanoma kind of viability, despite that inhibition. And so, for that reason, a lot of the work has been trying to see how can we block that from happening. Can we block the pathway further down at the level of MEK, for instance? So that's where a lot of the work has been published, and so that's where I think a lot of the data is currently. And that, of course, led to the approval of the combination of dabrafenib and trametinib, blocking the MAP kinase pathway at the 2 nodes. Mm-hmm. And by doing that, we improved the progression-free survival from about 6 months to 9 months now. And so it's a start, but obviously there's still more work that needs to be done.
And was there any significant increase in the adverse event profile using 2 agents versus 1?
Yeah, well, as you know, we can't get by. Nothing's free in this world, unfortunately. And so I think what was initially striking was the decrease in the cutaneous toxicities that we saw. And so by doing the combination RAF-MEK inhibition, we didn't see the cutaneous malignancies, the secondary skin cancers that we saw. But we did have issues with the fevers and the fatigue and so forth with the combination. So the spectrum of toxicities was different.
Good. What about the PI3 kinase pathway? Is this an escape mechanism if you blocked BRAF and MEK?
Yeah, and so the activation of parallel pathways is another way that the tumors can become resistant to BRAF inhibition. There are, again, a number of mechanisms that can do this that lead to activation of the PI3 kinase AKT pathway. There have been a lot of trials looking at dual pathway blockade. And again, the toxicities have been an issue with this sort of combination, as you might expect. Although with the combination therapy, we are seeing enhanced responses and so forth.
Very good. So is it appropriate, in the community for physicians to start patients off on a BRAF inhibitor plus a MEK inhibitor right from the get-go, or is it better to start just with a BRAF inhibitor and then if there's evidence of a sluggish response or progression, add in the MEK inhibitor at that point?
It's very interesting. Let me take that question a step back a little bit and then put this in the context of what we're seeing with immunotherapy as well. I think this is a question that we would have asked maybe 2 years ago, where we heavily debated, should we start a targeted therapy first or immunotherapy first? But I think this is really critical. I think because of the efficacy now that we're seeing with the PD-1 antibodies, alone or in combination with ipilimumab, which is still in clinical trial development, if patients have a modest burden of disease and we think do not need the immediate response that we might be able to get with targeted therapy versus immunotherapy, then many of us are going to use immunotherapy as frontline. That being said, if we have a patient with a BRAF mutant melanoma with a large burden of disease, symptomatic disease, who we need to achieve a rapid response, then the combination of BRAF and MEK inhibition is the standard of care.
Very good. Well, then tell us a little bit more about the evolution of the immune checkpoint inhibitors. Ipilimumab has been around for several years now, and according to some of the data that you presented, there's about a 20% very durable response, the sort of thing that we would see with IL-2, except at a higher percentage rate. But the toxicity can sometimes be prohibitive. And I know that the antibodies that have been approved now, the anti-PD-1 antibodies, nivolumab and pembrolizumab, have different toxicity profiles, but they're not completely without adverse events at all. How do you utilize these different agents, and where do you think they fit into the treatment algorithm?
Again, as we discussed at the conference, nivolumab, pembrolizumab are approved really as a second-line or third-line therapy in BRAF mutant melanoma. The NCCN guidelines have now said that it's a reasonable first-line therapy given what appears to be greater efficacy and a better toxicity profile versus ipilimumab, although that's not a recommendation, it's just a statement within the guidelines. Right. It is important to note that all of these agents have toxicities, and I think a lot of us who worked with ipilimumab early on had a very steep learning curve as to how to manage these toxicities and keep patients well. The spectrum of toxicities with ipilimumab versus the PD-1 antibodies can be very similar. So, we will see the dermatitis, we can see colitis, we can see hepatitis, the endocrinopathies, and so forth with all three agents, although the incidence of those toxicities varies by drug. With ipilimumab, of course, the dermatitis, the rash, the pruritus is observed in 40 to 60% of patients. We would see diarrhea, colitis in 20 to 40% of patients. And what we learned is that if we caught these toxicities early and instituted steroid or appropriate therapy quickly, we could keep them out of trouble. And I think by doing that, we were able to safely treat our patients with ipilimumab. And now I think with education, many oncologists are actually able to manage this. With pembrolizumab and nivolumab, the spectrum of toxicities are similar, but the incidence is less. But what we do see, and I guess let me caveat that, the incidence of rash and pruritus may be slightly less than what we see with ipilimumab. With colitis, that is definitely less. What we are concerned about is the pneumonitis, which we talked a lot about in the early trials because that's where patients got very, very sick. The incidence of pneumonitis is about 1 to 2%, so it is very uncommon, but it's something that you do have to catch early.
These steroid responsive?
It can be. They usually are. Clinically, what we did in the clinical trials and what we're doing now is that we do check a resting O2 sat and O2 sat during ambulation before treating, because that tends to be a very early marker of problems.
Okay, interesting.
But again, I think we have seen cases of pneumonitis that were not responsive to steroids, that were not responsive to infliximab or other immunosuppressants, and we did have patients die because of this. So this is something that, although rare, we do want to look out for.
Right. Is there much of a difference in the adverse event profile between nivolumab and pembrolizumab, or are they pretty similar, both being anti-PD-1 antibodies?
Yeah, that's a good question. They're very similar. And one question that's been asked, and I think we're asking ourselves, with two of these PD-1 antibodies approved now, which one do we use?
Right.
And that's a really important question. Looking across trials, the toxicity and efficacy data looks very, very similar. We have a little bit more data with nivolumab, certainly in the frontline setting. The scheduling is a little bit different. The dosing is a little bit different. But in terms of which is the better drug, it's impossible to say.
The results are pretty similar.
Exactly.
What about the anti-PD-L1 antibodies that are coming down the line? I know that Genentech has one, the NPDL3280A or whatever. I've seen a number of reports regarding that agent. How soon are we likely to see that in clinical practice? And once we do have those anti-PD-L1, and how will one decide where to start and where to move on?
That's a great question. I think the PD-L1 antibodies are, as you know, currently in clinical development. I think, when you look at where we're going with immunotherapy, I think it's not going to be in monotherapy, because we're going to face the same problems that we did with targeted therapy, where we are facing resistance. We are not curing all patients with melanoma with single-agent PD-1 or single-agent CTLA-4. We talked a little bit about some of the combination data that we saw with CTLA-4 and PD-1 inhibition combined, which is fairly striking, I would say. And there are a number of other combinations of immune checkpoint agents or immune agonists together, which are currently being tested, and which I think is where we're going to be going. So much like the combination of dabrafenib and trametinib led to improved outcomes, we might be able to overcome immunologic resistance with combination immune therapies.
There's been a lot of work done in melanoma over the years with vaccine therapies. Are there any trials being done looking at a combination of vaccine therapy with the immune checkpoint inhibitors, and do those look like they're going anywhere?
That's a great question as well. I think, again, pulling back a little bit, we might be able to improve the efficacy of immune checkpoint blockade, not just by combining two immunologic agents together, but combining it with some form of tumor ablation, whether it be radiation therapy, cryotherapy, radiofrequency ablation. That's being tested in clinical trials. We may be able to improve efficacy if we combine it with targeted agents, although we have to do that with a little bit of caution, as some of these targeted agents affect the immune system as much as they affect the tumor, and may in fact suppress the immune response. But yet, I think that's an important avenue to move forward in. There are ongoing trials combining immune checkpoint blockade with some of the agents such as TVEC, where we are, again, ablating the tumor with a local therapy. And, you know, with vaccine therapy, vaccines have been, as you know, quite challenging to develop.
Absolutely.
What was very interesting is the 2011 paper by Steve Hody, which was a randomized trial that combined ipilimumab with a GP100 vaccine versus a vaccine alone or ipilimumab alone. You know, the randomization scheme was such that it was a 3-to-1-to-1 randomization in favor of the combination of ipilimumab and that GP100 peptide vaccine, with the thought that the vaccine would help drive the immune response towards the tumor. And in fact, if you look at the outcomes, whether you got ipilimumab alone or with that vaccine, there was no difference. So at least in that case, with that particular vaccine, there wasn't an increase in efficacy. But again, you know, with the variety of vaccines and vaccination strategies out there, I don't think that precludes the possibility that this might.
What about in the adjuvant setting for patients who, you know, present with a BRAF mutant melanoma? There was some discussion this morning about the use of the targeted agents, the BRAF inhibitors and all. In the BRAF wild type, are the immune checkpoint inhibitors being looked at in that setting? And we know that high-dose interferon works, another, you know, immunological type of agent. So are drugs like the anti-PD-1 inhibitors or anti-PD-1 monoclonal antibodies being looked at in the adjuvant setting?
Yeah, and so those trials are in development now. Trials looking at ipilimumab have been completed in Europe, for instance, and Alex Egermont presented the data from the EORTC trial that looked at the use of adjuvant ipilimumab in this sort of setting, where we did see an improvement in progression-free survival, although it's too early to look at the survival data. You know, one issue with ipilimumab is the toxicity in the setting where patients may already be cured by surgery. And the hope is, as we do these trials with the PD-1 antibodies with a lower toxicity profile, perhaps the risk-benefit ratio may be a little bit improved. But those trials are certainly highly anticipated.
An amazing field you are involved in now. Considering what things were like 10 or 15 years ago, when we did have high-dose interferon and not a whole lot other than that, or maybe IL-2 and DTIC. It is just amazing the progress that's been made, and hopefully we'll continue to see dramatic improvement in our therapeutic alternatives. So Richard, thank you very much for stopping by and reviewing all this with us. was really interesting this morning, all the presentations, and it was great to have a chance to get your perspective on things.
Thank you very much.
Oh, you bet. And thanks to all of you. This is segment 2 from the first day, Friday at the annual NOCR meeting. We'll be back in just a few minutes with GI malignancies with Dr. John Marshall. So thanks so much. Hello and welcome back to the Best of the Day program from the 21st annual NOCR meeting. We've already covered breast cancer and melanoma, and now we're sitting down with Dr. John Marshall from Georgetown University to talk about some of the information that was presented this afternoon in GI malignancies. So it was an interesting session, one of the larger sessions with presentations on hepatobiliary carcinomas, upper GI cancers, pancreatic cancer, colorectal cancer, mutational studies, and a very interesting presentation by Wells Messerschmidt on the GI oncology pipeline. So John, thanks for stopping by.
Thanks for having me. I think I wasn't at the first one, but we've been partners before.
We've done this before. So I really only have 3 questions for you. And I want you to kind of go through each of the disease entities or categories that we talked about. So the first is, where has any significant progress been made recently in these diseases? What are the challenges that we're still facing? Is it identifying biomarkers, identifying molecular targets, finding agents to target the molecular entities that have been found? And then what looks exciting and interesting in the GI pipeline? Where is there a ray of hope that we can pin our hopes on? So let's start off with upper GI. That was the first talk today.
Yeah, so in terms of new stuff for upper GI cancers, I think mostly it is around understanding the genetics and why people get them, different ones, lower body of stomach, upper GI, GE junction, esophageal, but we're learning more about the fundamentals of the disease. But I honestly think in these cancers we really have not made a lot of progress. We've tried to understand how many chemos we should give and adjuvant therapy. Should we give radiation? What are the right treatments in metastatic disease? And really, when it comes down to it, we're still kind of at 5-FU and platinum. The role of a third drug, epirubicin, I don't know. We're not really sure that that's much use. And so in many ways, that could be seen as progress. We can be less aggressive and get the same outcomes. We don't need to beat these patients up quite so much. And maybe it's a softer, gentler touch, particularly in metastatic disease, that makes for better outcomes for our patients. We still also struggle a lot with sort of Asian Eastern approaches and Western approaches. Right. And there, I think it comes down to surgery. As Asian surgeons have sort of led the way in these more extensive nodal dissections that sort of lessened the role for radiation. We're starting to see that more and more in the United States.
The D2 resections.
Yeah, well, just more nodes in more experienced surgeons. The realization that not just an average general surgeon who would do 1 or 2 gastrectomies a year, the outcomes are much better in surgeons who are doing 2 or 3 a week. Right. And so that experience has improved our outcomes and maybe lessened the role for radiation. But we are still having the same debate in upper GI cancers about pre-op chemo, post-op chemo, role of radiation, the extent of surgery, and the like. So if anything, we've kind of backed off of the pedal a little bit in that disease.
So we've identified HER2 as one target in a 20-25%, depending upon where in the stomach, but we're still looking for targets for the other 75-80%.
Yeah, and they haven't really shown themselves. It's
EGFR hasn't been that important.
Tried
BRAF.
And didn't really play well. The BRAF's not going to play. And I think it's going to be a little like the story in colon, where there may not be these common major drivers. I think HER2, EGFR, HER1, HER2 pathway may be a little bit lucky for us in gastric. But you note one of the good questions that was asked today was, should we go ahead and incorporate trastuzumab in the adjuvant setting? In breast cancer, this drug, targeting this pathway, has transformed what used to be the bad pathway to now you want it. You want to be HER2 positive with breast cancer. And, so we're very eager to bring forward stuff that's working in the metastatic setting in the hopes that it would play in the adjuvant setting. And one of my answers to that question was, not so fast. It's not clear that what we're targeting in the adjuvant setting is the same cell that we're targeting in the metastatic setting. This has been true in colorectal cancer, clearly, where those drugs have not played in the adjuvant setting. And so our eagerness, gastric cancer is bad, very high relapse rate, and we want to try and help these patients. But it's not clear that trastuzumab in the adjuvant setting will help. We need to wait on the study.
So in the metastatic setting, trastuzumab seems to be most effective in the patients who are IHC 3+ or FISH. Is it possible that a drug like TDM1 might work pretty well even in the patients who are IHC 1 and 2+?
Well, even in the breast cancer world, there's, that group is still fussing over who's positive, who's negative, who we should try the drugs in and not. And that's 15 years since the discovery of HER2 targeting. So I don't know the answer to your question. I think it's absolutely worth trying. I think it's important to try, in fact. But as you point out, it's still a relatively small subset. Could we broaden it a bit by doing some of these fairly simple and quick clinical trials? Yeah, I think we could, and worth doing.
Very good. Hepatocellular and hepatobiliary. We know gemcitabine, cisplatin in the biliary tract, and sorafenib and hepatocellular. Are we making any additional progress down those pathways?
We haven't made a lot of progress on the back end of these diseases, in metastatic disease and the like. I think the role of transplant, the role of liver-directed therapies for actually both, biliary is most commonly hepatocellular, that's clearly taken hold. There's widespread recognition. More and more people are being identified and referred for those procedures. So that's good. I think the most exciting news, for those of us who take care of liver cancers, is the prevention side. With new therapies that actually will interfere with and reverse Hep C, for example, better screening clinics for Hep B carriers, the recognition of obesity and NASH and these risk factors. So we now have a way on the sort of front end to try and reduce this really growing global health problem.
Like smoking and lung cancer.
Yeah, exactly.
Yeah, very good. All right, well, let's move on and talk a little bit about colorectal. I mean, a few years ago, regorafenib got approved with a progression-free survival difference of about that much, multi-targeted agent. I don't know if anybody knows exactly what the target is it's hitting that makes the difference, but what else is coming down the line? We know that it's not just KRAS, but KRAS and all RAS that are not eligible for the EGFR targeted agents. What more are we learning about colorectal cancer and how to deal with it?
You can't emphasize the RAS story enough, and this has not gotten good traction in the United States so far. I think it's today or yesterday there was a label change for panitumumab, which now actually says we want extended RAS testing for everybody. So that's important. But we are still seeing, it took a while for docs to catch on to the KRAS story. And just when we started preaching KRAS, of course we changed the rules on everybody and said, oh, it turns out there's more RAS than just KRAS. And it took a while for molecular testing groups and institutions to figure out how they were going to test all these people. So we are still seeing, Wells mentioned it during the talk, that we're all seeing patients who've not been fully RAS tested. And the importance here is that if you do have one of those any of the RAS mutations, at least as far as we know now, taking these medicines, the EGFR targeted antibodies, can cause harm. So it's not a no harm, no foul, let's just see.
Right.
It's not only expensive, it's not only rash, we may be in fact, reducing survival with it. So I like to tell the story that I sort of made the decision for our healthcare system in Washington that when the KRAS story came out, I said, okay, everybody's going to get KRAS tested. If we have colon cancer, we're going to test everybody because it was just simpler. Well, as soon as I made that suggestion and they adopted it, of course the rules changed. So now all of those people that we had to test, we're having to go back and test. And this actually brings up a different theme that came from our discussions, and one that's increasingly interesting to me, and that's the idea of pan-profiling. We're in this awkward in-between of, is it better to a la carte order your genes on the sample, or should you just test everything that we know today? And it's getting to the place where those are almost the same price, although clearly, doing broad molecular profiling is more expensive at the moment. But I think about, I order a Chem 20 every day of the week.
Sure.
Do I need every bit of that Chem 20? No, but it's bundled. It's better for me to get a Chem 20. And so the question is, should we be moving in that direction? Well, insurance companies are rightfully saying, well, I don't want to pay for that. I'm paying for research in a way. So they rightfully are arguing against that. But if we don't start doing this broad profiling, we're not going to figure out what's making these cancers tick. So we're in this awkward in-between of a cool technology and it really not firmly being adapted. And there was a lot of discussion about that, particularly around colorectal cancer. A lot of what Wells was talking about in his presentation and new targets was we're going to have to uncover them, and we got to keep looking. And yes, there are things like combinations, so hitting against EGFR and BRAF at the same time. That's an interesting thing that's going on. MEK inhibitors in the right kind of patient, those are going on. But the reality is, even immunotherapy has not been all that promising so far in the GI cancers. Although we know it works, it's not been the home run that it's been in some other cancers.
What is the role of JAK2 overexpression in colorectal cancer?
Well, so far we don't have one. It's being looked at in a couple of disease areas, pancreas being one of the main ones. But it's obviously a heme thing, and the question of whether this pathway might have a role on a stroma, might have a role in cachexia, this sort of thing. So this sort of, off-target but paraneoplastic side effect of cancer, it may be that these kinds of things are going to help in a couple of big studies being done right now to try and prove that.
I know there's a regorafenib plus or minus ruxolitinib trial going on right now, so that will be interesting. So pancreas, Andrew Koh gave a very nice presentation this afternoon on an update in pancreas, and he talked a lot about MM398, which is moving along. There's some very interesting data. Tell us a little bit about that drug. What is it? It's got an interesting number, but I don't know if it has a name yet.
I don't know its name either, but actually I never thought I would be saying this, but pancreas is where the action is. Before going there, let me kind of set the stage. I think back 20 some odd years ago when colon cancer, all we had was 5-FU. In pancreas, the same length of time we sort of had some 5-FU, we had some gemcitabine. But all of a sudden, with a combination of Abraxane, nanopaclitaxel with gemcitabine, and now a 5-FU based with oxynury, we're coming off the floor, and it reminds me, actually I'm stealing this from one of my partners, a guy named Mike Pishvane, of those early days when Ox and Erie were beginning to improve our outcomes in colorectal cancer. So we're very hopeful. And quick on the heels of that progress has been some new targeted agents which are helping. And the agent you're referring to is just sort of fancy irinotecan. It's a liposomal. If you sort of think of Abraxane to Taxol, this is the same basic principle with irinotecan. And the good news is that we're seeing some early clinical activity. It looks like it'll mix with chemotherapy, some clinical trials ongoing, and some data that's out there where it's being reviewed right now. So we may well have yet another agent in play in pancreas cancer. And you know, Andrew boldly but correctly started talking about second and third line pancreas
Right,
cancer.
and whoever thought that would have come.
You know, that
yeah.
patients would be well enough to do that. So we're excited about that. What we got to figure out, and this is sort of my own personal clinical observation, is that there appears to me to be a group of patients who respond really well to the FOLFIRINOX recipe
Right.
and not Gemabraxane, and vice versa. And so we bring to the table a sort of bias based on performance status and age that I'm going to try X regimen or Y regimen, when in fact, again back to the profiling, I foresee a time when we would have some sort of testing that would tell us that, no, you're a FOLFIRINOX patient or you're
Right.
a Gemabraxane patient.
We need predictive profiles.
Badly. Yeah.
Yeah, absolutely. All right, John, thank you so much.
Thanks for
This
having
was
me.
really interesting. I should also mention that John gave a phenomenal talk at lunch today about challenges for oncology practice in the next decade or so, and it was very worthwhile, and it will be part of the webcast for this meeting. So in 8 weeks, when that webcast is available, I would strongly recommend that you tune in on the IMEDX website and watch that presentation. It's really very interesting. So thank you so much for that as well.
Jim, thanks very much.
All right, and thanks to all of you for watching this day one segment of Best of the Day from the 21st Annual NOCR meeting. We'll be back tomorrow with even more information. Thanks again.